Dear audience, may God bless you all with peace and tranquility. Most warm welcome on behalf of AETCM. Today we are going to discuss about acute pulmonary embolism. And I am Professor Dr. Dhanasegaran, attached with Amrita Institute of Medical Sciences. Under this topic, we are going to cover acute pulmonary embolism caused by thromboembolism. There are various types of other emboli also. So our topic will be only about thromboembolism happening in the acute phase in the pulmonary artery. And we have to have a clear knowledge about what is meant by embolus or emboli, what is meant by embolism, what are all the various types of emboli present, and then we go to the topic per se. This topic does not encompass all in detail about the thrombus formation in the deep vein. That will be covered by yet another colleague of mine under the heading deep venous thrombosis. So all the pharmacological aspects, medicine, investigations and all in depth the topic will cover. So I will be just quoting some of the important key points pertaining to the acute pulmonary embolism. Before entering into the topic, just let me play a video. Just a short time, it will be on the screen.
Very large thrombus obstructing the main pulmonary artery at the branch point between the left and right main pulmonary artery. You can see how utterly large this pulmonary embolism is as we remove it from the pulmonary artery. It measured over 11 inches in size. On further inspection, there was even more embolic material. This is all thrombus that originated from the patient's lower extremities or her legs. She had a deep venous thrombosis, which then moved into her heart and caused this pulmonary embolism. You can see why DVTs can be life-threatening when they become pulmonary emboli. You can also see the clot extends into the small branch points in the pulmonary artery. This was removed as well. Here is the specimen that was removed from the patient's pulmonary artery. You can see it's almost a perfect cast of the patient's common femoral vein and iliac vein.
She could have captured from this wonderful video a very huge thrombus is being removed from the pulmonary artery. They have done this by surgical embolectomy. Unless otherwise on time they could have done it, the patient life is finished. Okay, surgical embolectomy is a procedure, they have done it, and a very large and long and huge thrombus, thromboemboli, they have removed from the pulmonary artery. Okay. So now we go to the terminologies. What is meant by embolus or emboli? Embolus is singular like bronchus. Emboli is plural like bronchi. So it's a Greek word, embolus, that means wedge or plug. Any material other than the component of blood that travels along the blood stream until it gets trapped or lodged in the vascular tree is called an emboli. There are various types of emboli. One is thrombus, now we have seen it in the screen, and another bacterial clumping, that is vegetations, fat emboli, and amniotic fluid around the labor, and then air emboli and catheter embolization. The embolism is a phenomenon of lodging of an embolus in the blood vessel. Emboli is a plug or wedge. Embolism is the phenomenon of lodging of an embolus in the blood vessel, which causes block to the flow of the blood. It may be a complete obstruction or it may be a partial obstruction. So thromboembolism, here the fragmented or detached portion of a huge thrombus may be traveling along the bloodstream to cause the embolism. So here we are discussing about acute pulmonary thromboembolism. So the acute pulmonary thromboembolism definition is detached or broken fragments, that's called an embolus, of a venous thrombus reaching the right ventricle and entering the pulmonary artery, that is pulmonary trunk, to cause sudden obstruction in any part of the pulmonary circulation. This incidence is very common and mortality rate is also very high. So what is DVT? DVT, the deep vein thrombus, is the origin or the source where from the thrombus gets detached. So we are going to discuss about certain practical aspects about the DVT, that is source of the thromboemboli, what are all the common sites, the venous thrombolysis, and how the thrombus is formed, and the risk factors involved in the formation of DVT and pulmonary embolism. Which population of people are more prone to have the DVT and pulmonary embolism? How to arrive at the diagnosis of the presence of DVT and how to manage DVT. These are all the things we will be covering in brief. The source of the thrombus. So the most common source is the lower extremity proximal veins. Remember, proximal veins. That is iliac, femoral and popliteal. So 50% of the pulmonary embolism is from these sites. So we always deep vein, cough vein thrombus. The cough vein thrombus dislodging is very rare. 2/3 of the cough vein thrombi resolve spontaneously after deduction. The rest 1/3 extends to the proximal vein. Only from the proximal veins the detachment or fragmentation of the thrombus happens to travel to the heart and the pulmonary vessel. And DVT may happen in non-lower extremity veins also. Example, right heart, inferior vena cava, pelvic veins, renal veins. Rarely upper extremity also there is thrombus formation. Most often it is iatrogenic, intravenous catheterization or intra-heart. This one central venous line. So many things may be causing this one. So sites of the thrombi development inside the vessels is near veins is near the valve cusp or bifurcation, where the flow of blood becomes turbulent from the laminar flow. There are three factors which is very common to cause the thrombus formation. You all know Virchow triad. One is venous stasis, number 2 is endothelial injury, number 3 hypercoagulable state. Each factor has got its own many causes for venous stasis, endothelial injury. So what are the risk factors of thrombosis? So this is common for both venous thrombosis and pulmonary embolism. So inherited genetic risk factors or acquired risk factors, provoking factors like recent surgery, trauma, immobilization, etc. and non-provoking factors like obesity, cigarette smoking, heavy smoking, etc. And there are certain special population who are all more prone to develop venous thrombosis and hence the pulmonary embolism. Patients with malignancy, pregnant ladies, stroke patients, certain medical condition patients, surgical patients, and nephrotic syndrome. These are all some of the population groups which are more prone for development of the thrombus. And from the venous end, from the source, now the thromboemboli is traveling and reaching the heart, right atrium to the right ventricle, then it starts traveling into the pulmonary artery. So it is a picture depicting the pulmonary trunk and its branches. So the main trunk, pulmonary trunk, divides into right and left pulmonary artery. So the branchings are happening in a similar fashion like the trachea is divided into primary main bronchus, right and left, or further divisions, lobar divisions, and then segmental division and subsegmental. Same pattern the pulmonary artery also follows. See the right and left pulmonary artery, then lobar to segmental, segmental to subsegmental. Depending on the size of the emboli, anywhere they can be plugging or get trapped. So the same following. See this one. See, this is the main bronchi. There is a main pulmonary artery, right and left, and then lobar, that is depicted in yellow color, and then green segmental, and then last one is subsegmental. So where the emboli get trapped is more important in the formation of the clinical presentation. Then coming to the types of the pulmonary embolism based on the onset, it may be either acute, subacute or chronic. Based on the symptoms, some of the emboli may be symptomatic, some may not be having any symptoms. Based on the site of the embolism in the pulmonary artery, one side, the right main branch or left main branch or both the branches might have been blocked. That is embolus in the pulmonary trunk, right, left or both main pulmonary arteries. And going further, smaller lobar, segmental and subsegmental pulmonary embolism. So depending upon the anatomic location of the embolus, see, once it is getting detached from the source, it is directly not going to the pulmonary artery. Sometimes it may be in the right ventricle itself, not entering the pulmonary artery. So this is called the clot in transit. So we cannot search for the presence of the thrombus emboli inside the pulmonary artery. It is still in the right ventricle. But here the mortality is nearly 70%. And another emboli is called pulmonary embolism, saddle pulmonary embolism. This lodges at the bifurcation of the main pulmonary artery, often extending into the right and left main pulmonary arteries. So most important classification of the pulmonary embolism is based on the hemodynamic stability. There are two types. Whether the patient is received in the emergency department, first thing you have to assess is whether the patient is stable or patient is hemodynamically unstable. Here the hemodynamic unstable means a little different thing from other unstable patients. Remember, there is a cause, that is a hemodynamic instability is because of the low blood pressure. The definition for this hypotension is either the systolic BP should be less than 90 millimeters of mercury. There should have been a drop of systolic blood pressure from the original baseline by more than 40 millimeters of mercury, and is persistent for nearly 15 minutes or more than 15 minutes with or without treatment. And for the correction, apart from the IV fluids, it may require vasopressors or inotropic support. And most important last factor is this fall in the BP or the instability is not explained by any other cause, such as sepsis, arrhythmia, left ventricular dysfunction from acute myocardial ischemia, or infarction or hypokalemia. So the hypovolemia, these are all the common causes for the hypotension. These causes will not be included in causing this type of hypotension. This is purely because of the block of the pulmonary artery, which is causing the cardiac output reduction, leading on to the profound hypotension. Sometimes it may go unmanageable also. So what are the causes for the hemodynamic instability? Either massive or large or high risk pulmonary embolism. So don't think that always this massive embolism will have symptoms. Certain times the massive emboli may have no symptom at all, but the patient may go for sudden death. So also the smaller emboli, don't think it may not produce any hemodynamic instability. So the smaller emboli also may cause hemodynamic instability because of the any coexisting cardiopulmonary comorbidities. So always whenever examining a patient, don't estimate the patient on the size of the thrombi. Okay. So the prognosis of the patient, death. So mostly within first 2 hours, if the emboli is causing a major block, the major cause of the death is the obstructive shock or right ventricular failure. Remember, the cause is obstructive shock or right ventricular failure. That management is entirely different when you are dealing with the hemodynamic instability. or the risk may be persistent for even up to 3 days. So don't in a hurry try to send the patient after observation and discharge. So pathophysiological effects of the pulmonary embolism. It has got its effect on many of the systems. One, in the respiratory system, the common site affected in the lungs are the lower lobes. So smaller emboli, multiple in nature, they will be causing this emboli there. The respiratory compromise, abnormal gas exchange. The patient, when you are assessing with ABG, may be showing hypoxemia. Remember, hypocapnia, not usually we used to think hypercarbia and respiratory acidosis. It is not so. Hypocapnia and respiratory alkalosis. Because this is because of the inflammation causing the stimulation of the respiratory center, producing tachycardia, and so the patient is going for the hypocapnia and respiratory alkalosis. And pathology, pulmonary infarction or pleuritic inflammation, that is caused by smaller emboli. The incidence is 10%. So this may be clinically presented as pleuritic chest pain or hemoptysis. Remember, hemoptysis is the end result in some patients with pulmonary infarction or pleuritic inflammation. So on the cardiovascular system, hypotension is the most important thing, the compromise. So this is caused by large multiple emboli or small emboli with cardiopulmonary comorbidities. The mechanism is diminished stroke volume and cardiac output. So other factors, this is the pathophysiological mechanisms. Okay. So this patient may be having increased pulmonary vascular resistance, and then there may be right ventricular dilatation. So flattening or bowing of the interventricular septum. So the septum will be, interventricular septum will be pushed towards the left, causing the volume of the left ventricle also reduced. So the final end result is the hypotension. So what are the clinical presentations this acute pulmonary embolism will have? So wide varieties of presentation, all the signs and symptoms are non-specific, asymptomatic to shock or sudden death. So many of the patients may have associated signs and symptoms of DVT in the extremities. There is swelling, erythema, pain, tenderness or tightness of the limb. And remember, the signs and symptoms are evolving in nature. That is, initially the patient may be having mild symptoms. Over a period of time, the patient may become unstable and going for a life-threatening situation. So the close observation and monitoring of the patient and timely diagnosis is most important. Sometimes this evolving of the symptoms may happen in minutes to hours, or it may be delayed over weeks or days. So the cause for the evolving signs and symptoms may be either the disease pulmonary emboli itself is progressing, or there may be recurrence of the embolism after the treatment is being instituted. This is a long list on the left side of the signs and symptoms of the pulmonary embolism, starting from dyspnea, chest pain, cough, hemoptysis, and it may go to the level of syncope, and then clinically signs are jugular venous distension, an accentuated pulmonic component of the second heart sound, fourth heart sound, decreased breath sound, so many things. When coming to the differential diagnosis, so the common differential diagnosis include heart failure, myocardial infarction or ischemia, pericarditis, and so on, pneumothorax and so other many things. So remember, pulmonary embolism may coexist with any of these conditions or vice versa. Don't give only one diagnosis of pulmonary embolism. It may be associated with myocardial ischemia or infarction or any other condition also. The most important laboratory test, the laboratory tests are not diagnostic but confirm the presence of alternative diagnosis or comorbidity. For example, these are all routine things. Random blood sugar, ABG, serum troponin to rule out myocardial infarction, serum creatinine to renal function assessment. It will be useful when we are going for a contrast dye injection. And CBC, bleeding profile coagulation studies baseline is most important, because in the management strategies we will be incorporating anticoagulants and thrombolytic agents also. And a D-dimer and adjusted D-dimer to know about the presence or absence of the DVT. See, the negative is less than 500 nanogram per ml, and then positive is more than 500 nanogram per ml. Remember, an elevated D-dimer alone is not sufficient to make a diagnosis of pulmonary embolism. Then electrocardiography, it may have certain specific features. S1, Q3 and T3, this is very uncommon. It may be present in less than 10% of the population who are having pulmonary embolism. If it is present, we can have the probability of suspecting pulmonary embolism. Apart from this, there are certain ECG changes that will predict the poor prognosis of the patient. One is patient is going for atrial arrhythmia like atrial fibrillation, bradycardia, tachycardia, new right bundle branch block, or S1, Q3, T3 pattern. These are all the things which will be predicting a very bad prognosis. So also in the chest X-ray, this is not necessary if you are planning for CTPA. So directly we can go for it. So here the chest X-ray will be useful for the diagnosis of an alternative cause or comorbidity. So this is the most important chest X-ray. Suppose we can't able to institute CTPA, with the other option is ventilation perfusion scanning, which needs a normal chest X-ray. So for this, chest X-ray may be of help. And there are certain signs, these are very rare signs occurring in the pulmonary emboli. There is Hampton's hump, Westermarker's sign, Paulus sign. I don't want to go into the descriptions of all things, it may be taking a lot of time. And diagnostic approach to the patients with suspected pulmonary embolism. So patient evaluation, see, simultaneous evaluation and resuscitation and diagnostic investigation, all these things should go together. So evaluation of the patient, first to rule out or confirm the possibility of presence of venous thrombosis. This is for the administration of empiric anticoagulant at the earliest. And then history taking should always include the risk factors pertaining to the venous thrombosis or pulmonary embolism. And you have to keep in mind about the special population who are more prone for venous thrombosis, and medications and past history regarding whether the patient is already on any thrombotic events. Then clinical examination. So we have to first examine the probability of the presence of both DVT and pulmonary embolism. So careful clinical examination, gestalt estimations. Here comes the pre-test probability assessment for the pulmonary embolism. So there are Wells and modified Wells criteria to classify if the pulmonary embolism or venous thrombosis is there. Low to intermediate or very high probability. And pulmonary embolism rule out criteria. These are all the certain things you should be a must to incorporate in the clinical examination. And then we have to assess if the patient is having any bleeding risk. When you are thinking about administration of the anticoagulants, which should have been done, and thrombolytic agents. And expected timing of the diagnostic test, any undue delay to wait for getting the confirmed test is being done. And then investigation and D-dimer and adjusted D-dimer. Okay. And the definitive diagnostic imaging, if the patient is, again depending upon the hemodynamic stability of the patient, if the patient is hemodynamically stable, we can submit here for all the definitive confirmative diagnosis tests. If the patient is hemodynamically unstable, accordingly we have to go only for the investigation which he can withstand. The definitive diagnostic imaging is CTPA, computed tomographic pulmonary angiography. This is a definitive imaging for the pulmonary embolism diagnosis, most accurate to detect embolism in the pulmonary artery up to the subsegmental branches. The recent times, the most modern equipments can able to pinpoint even up to the subsegmental branches the presence of the pulmonary emboli. So this is again neither catheter-based pulmonary angiography. If the patient cannot be exposed for the irradiation, we can go for the magnetic resonance pulmonary angiography. So if the patient is hemodynamically unstable, so we have to opt only for the ventilation perfusion scanning. In the present day, they are having bedside equipments also to do this procedure. So in patients hemodynamically unstable, definitive imaging is unsafe for this patient. So just a patient shifting itself, the patient may collapse. So next is we have to rule out the possibilities of any deep vein thrombosis. So remember, this is not for excluding the pulmonary embolism. It's presence. That is venous compression ultrasound, lower extremity compression ultrasonography with Doppler. To check for embolus in the transit. I told sometimes the emboli may be in the right ventricle itself. So this may be done by the help of the bedside echocardiography, or if it is available, transesophageal echocardiography, which will be more sensitive, more accurate. And I have talked about already the chest also. So the echocardiography will give certain important findings. So this we can find out the increased RV size, decreased RV function, tricuspid regurgitation, and so many things. Transesophageal echocardiography is most accurate. It can even detect the embolus present in the right heart, that is the emboli in transit. So it may detect even the main branch or saddle pulmonary embolism also can be detected by transesophageal echography. This transesophageal echocardiography is one under the monitor of which we are doing the thrombolysis or embolectomy, non-surgical embolectomy. And then management aspects. Whenever you are suspecting a pulmonary embolism, the patient is unstable. The unstable patient first management is resuscitation and stabilization. And remember here in the resuscitation, sometimes the patient may warrant going for an endotracheal intubation or mechanical ventilation. This is a double-edged weapon. So this may sometimes worsen the patient. Because of the sedation, because of the induction agents, the hypotension may profoundly go for serious conditions. And one more factor you have to keep in mind is the positive pressure ventilation. Again, it will cause further fall in the blood pressure. So the effects of the positive pressure ventilation, compression of the failing right ventricle, causing the reduction in the preload, and then it may cause the hemodynamic collapse. And then IV fluids, here again you have to keep in mind, this is not a hypovolemic shock or any other cause. This is because of an obstructive shock. So the more amount of fluid you are giving, the more deterioration the patient will go for. So remember, only boluses of 100 ml, slowly we get to institute the IV fluids. Okay. Then regarding the vasopressors, norepinephrine is the choice. Sometimes it may be we can use dobutamine, but only thing is dobutamine, as far as its use is concerned, we used to start only in lower dosages, then slowly we will be increasing. Dobutamine in the lower dosage of administration as infusion will cause profound vasodilatation, which will add further fuel to the fire, causing the hemodynamic instability. So to avoid this one, you can have a starting with the combination of norepinephrine and dobutamine in a lower dosage. Then once the patient BP is slowly maintained, you can increase the dobutamine till the time the BP is coming up. Then you can think about whether reducing or weaning out the norepinephrine part. Don't start dobutamine alone and higher dosage at the starting itself. Okay. Then the empirical anticoagulation without, this is an empirical anticoagulation. The earliest it has to be administered. So when it is that, if there is absence of any risk of bleeding, there is no other contraindication for the anticoagulation, then it should be administered. And it also goes with the pre-test probability of pulmonary embolism that is high, or the diagnostic imaging is unduly delayed. So sometimes we need to start the anticoagulation even before the diagnosis of pulmonary embolism is confirmed. So the most important thing, you should have a thorough knowledge about all the drugs used, anticoagulants, thrombolytic agents, including the selection of the choice of medication to suit the particular patient. So don't forget about the baseline investigations, bleeding profile, coagulation study and CBC, and we should be again and again repeated at periodic intervals to know the therapeutic efficiency of whatever drugs you are giving. The contraindications for the anticoagulants are many. Absolute contraindication, prior intracranial hemorrhage, malignant intracranial spinal cord neoplasm and other things. Okay. Significant closed head trauma or facial trauma within 3 months, hemorrhagic stroke. These are all some of the causes to enumerate the contraindications. Relative contraindications are also many. I don't want to read all one by one. We can just go through the PPT. And most important relative contraindications you have to keep in mind are pregnancy, postpartum, active peptic ulcer, pericarditis, pericardial effusion, and age above 75, and diabetic retinopathy. Remember, if the patient is having a menstrual bleeding or an epistaxis, this is not contraindication for the administration of anticoagulants. Sometimes minor hemoptysis, there is no contraindication for the administration of anticoagulants, because this itself may be a sign or symptom of the pulmonary infarction. So the treatment is, one of the treatment is anticoagulants. Not massive hemoptysis, only minor hemoptysis, there is no contraindication for the anticoagulation. Always remember about this special population of the people, they may require certain dosage administration, specific anticoagulant or alternative treatment. Example, pregnancy, postpartum malignancy, patients with heparin-induced thrombocytopenia, inherited thrombophilia, antiphospholipid syndrome. These are all the things you have to, selection of the agent, dosage, everything should be kept in mind. Empiric anticoagulant, optimal agent selection depends upon certain factors. One is the presence or absence of the hemodynamic stability. Number two, whether you are going to do any procedures like thrombolysis or non-surgical embolectomy or surgical embolectomy, and the presence of risk factors and comorbidity. These are all certain factors which will decide about the optimal agent selection regarding the anticoagulants. So just to cite one or two examples, low molecular weight heparin. This is chosen for the patients who are hemodynamically stable, but unfractionated heparin may be selected for the patient who are unstable. And low molecular weight heparin should not be used in the renal insufficiency, but unfractionated heparin can be used in the renal failure patient. As far as we are selecting the unfractionated heparin, caution is heparin-induced thrombocytopenia. And the most valid important thing you should remember is direct thrombin or factor 10A inhibitors should not be used in hemodynamically unstable patient. Yet another treatment modality is the veno-cava filter placement in case anticoagulants are contraindicated. So the placement of the veno-cava filter in appropriate place will prevent the further thrombi reaching the heart. So it will be filtered and prevented. So now, patients with life-threatening pulmonary embolism. See, we have seen in the video one of the patient who was in the life-threatening pulmonary embolism. What to be done in that case? So now we have to go for the reperfusion therapy. Again, two separate therapies are there. One is thrombolytic or fibrinolytic therapy. Another one is embolectomy. So what we are doing in thrombolytic therapy is systemic thrombolytic therapy. It can be given intravenous or it can be catheter directed thrombus removal with or without thrombolysis. So only this is in the latter, the dosage we are administering will be precisely at the site of the thrombus which is blocking or emboli, and the dosage will be minimized. Thrombolytic drugs dosage will be minimized. So indication, high risk or massive pulmonary embolism, that is in the presence of hypotension related to pulmonary embolism. Say potential indication, you should consider case by case and you should always weigh the risk versus the benefits of administration. Okay. Patients with severe right ventricular dysfunction due to pulmonary embolism, that is intermediate risk pulmonary embolism, we have to keep in mind. Other indications for the thrombolytic therapy is presence of severe hypoxemia and patient with acute pulmonary embolism who appear to be decompensating but are not at hypotension, going to happen, anticipated, and extensive clot burden, severe tachycardia. So the indications for the thrombolytic therapy. And then comes the embolectomy. So there are various types of embolectomy are there, surgical and non-surgical, that is catheter directed modalities, under which there are many types, and then surgical embolectomy that you saw in the video. And apart from all these things, the patient is unstable. What can we do till either we go for a thrombolytic therapy or a surgical or non-surgical embolectomy? How to tide over the crisis? Here comes the extracorporeal membrane oxygenation for the rescue. So apart from that, there are some adjunctive therapies are there, general medical care, and then after the treatment, the patient should be ambulated earlier, and elastic graduated compression stocking in the extremities and inferior vena cava filters. So now comes this hemodynamically stable patient. So far we are talking about hemodynamically unstable patients. So once pulmonary embolism is confirmed, the patient condition is stable. Now we have to assess about the risk of bleeding, whether there is nil or low risk bleeding. In such cases, we can opt for anticoagulant. Intermediate risk of bleeding, the decision is individualized based on risk-benefit ratio. The ball is in your court to decide whether to give or not. You have to substantiate why do you want to give. And then high risk for bleeding under contraindication to anticoagulation. So immediately inferior vena cava filtration, just to prevent further recurrences. Okay. So remember, IVC filter placement may not be certain times possible if the thrombus or the tumor is extensive. So in such cases, the alternative is administration of the anticoagulant if there is no contraindication for the same. Pulmonary embolism is proven and the anticoagulation is contraindicated, an IVC filter is mandated, whether the pulmonary embolism is small or extensive, even in the absence of residual deep venous thrombosis. Remember, underline, even you cannot able to pick up by the ultrasound methods any presence of the deep vein thrombosis. Even then, we have to go for the anticoagulation. So there may be origin of the thrombus from some other veins, not necessarily from the deep venous system in the extremities. Okay. So that you have to keep. It may be from the pelvic veins, it may be from some of the abdominal veins. So this may happen and it may cause the recurrent pulmonary embolism. So the prognosis, adverse effects and complication, one is recurrent venous thromboembolism, and then patient may go for chronic thromboembolic pulmonary hypertension. This is a late outcome. Okay. and then death. So if this is untreated, 30% mortality in hours to days. The death may be because of the shock or recurrent thromboembolism or associated comorbidities. So this much in the care is not stopping alone. See, whenever the patient is, then we have to continue our monitoring and follow up certain things. So we have already discussed about the on-arrival baseline, and we have to monitor for the early complications, either due to the progression of the emboli, diagnosed pulmonary embolism, or recurrent thromboembolism. In case of recurrent pulmonary embolism, evaluate for subtherapeutic anticoagulation, that is inadequate dosage of anticoagulation is one of the cause for the recurrent pulmonary embolism. Other causes of recurrence, late complication of pulmonary embolism, and then this manifests in the first 2 years of the following pulmonary embolism. And next, follow-up and monitoring should be done for the complications of the therapy, anticoagulation therapy, thrombolytic agent therapy, that is bleeding, and then adverse effect of medication or devices. Sometimes the vena cava filter itself may be dislodged from its original place of placement. So sometimes after some time we have to remove the filter also. Is there any need for the removal? We have to assess. Patient examination calmly, have your mind very cool, final outcome, conquer, come out with flying colors. Best wishes, dear students.